Good afternoon, and welcome to the Lewy Body Dementia Association's LBD University program. I'm Angela Taylor, LBDA's Director of Programs, and your host and moderator for today's webinar. This year, we're pleased to offer a series of 3 Ask the Expert webinars. Today's expert is Dr. James Leverenz, the Chair of LBDA's Scientific Advisory Council. He will present an update on LBD research, a focus on genetics. Dr. Leverenz is the director of the Cleveland Lou Rouveau Center for Brain Health and the Joseph Hahn, MD, Endowed Chair of the Neurological Institute at the Cleveland Clinic. His primary clinical and research interests are the aging-associated neurological disorders, with a particular focus on Alzheimer's disease, Parkinson's disease, and dementia with Lewy bodies. He's an investigator in the Michael J. Fox Foundation-sponsored Parkinson's Progressive Marker Initiative, or PPMI, study, and is the pathological core leader for the PPMI program. Today's webinar will begin with Dr. Leverenz's presentation and will be followed by a question and answer period. To submit your questions, please use the Questions tab on the control panel on your screen. Please feel free to submit your questions throughout the presentation, and following its conclusion, I will present your questions to Dr. Leverenz and will address as many as possible in the time allotted. In addition, the Handout tab of your control panel contains resources you can print or download for future use, and that specifically is today's slides. So I am pleased at this time to turn things over to our guest, Dr. Jim Leverenz.
So good afternoon to everyone, if you're on the East Coast or wherever you happen to be. And we'll probably try to pull the slides up now. And let's see here. Here we go.
Perfect.
Okay, we're in good shape. So thanks for the lovely introduction, Angela. And my job today, which maybe I'll switch to the next slide here, is, first of all, talk about any disclosures, should you want. None of these are really relevant to today's discussion, but to be fully disclosed, these are companies I either consult with or have received grant support from. And just an overview of what I want to talk about this afternoon. First of all, I want to make sure that we're all on the same page. So I'm going to start with some definitions, things like Lewy body dementia, dementia with Lewy bodies, etc., even what the term dementia means. And then a brief overview of genetics, and then discuss some of the work that I've worked on and colleagues have worked on around the genetics of Lewy body dementia, particularly thinking skills in Parkinson's disease, as well as genetic risk factors for dementia with Lewy bodies, and then we'll open up for questions at that point. So, first definition is what is a Lewy body, so spelled L-E-W-Y, and named after a pathologist named Friedrich Lewy. And you can see in the center of your screen here, and I'll take my arrow here as well, and you can see a brain cell here. We know this is a part of the brain that we call the substance black or substantia nigra because the brain cell here has this pigment in it. And if you can see, this is a fairly normal cell up in the upper right-hand corner here. And this is an abnormal cell because it contains this little inclusion here, this round body with a halo around it that's pink with this particular stain. This is what Friedrich Lewy called an inclusion, but we now name after him, so that is a Lewy body. And that's what we're going to discuss today, is disorders linked to that inclusion. Now, at this point, we can only see these inclusions in people where we can look at their brain under the microscope, and we can only do that once they are no longer alive. So only at autopsy can we see these currently. We can, as we'll talk about later, guess whether they're there or not based on the clinical symptoms that a person has, but ultimately it's the autopsy that tells us for sure what's been going on. The next slide shows another important point about the Lewy bodies. So this is a stain using an antibody to a protein called alpha-synuclein. And you can see that word on the upper left here, alpha-synuclein. this is a protein that we all have. It's thought to play an important role in how our brain cells communicate to each other. And it is the primary component of the Lewy body. So this is sort of a Lewy body, as we saw in the previous slide here, stained for this protein. And you can see it stains very darkly for that protein. And so we know that this alpha-synuclein protein is a very important part of the Lewy body disease. Also important, we know, and we won't talk about it too much later, but we know there are certain rare genetic forms of Lewy body disease, particularly Parkinson's disease, that are linked to changes in the gene that makes this protein that we all have, or that if you have more than the usual 2 copies of this gene, you can get Parkinson's disease. So we think this protein is very important in the cause of the Lewy body disorders, and I think it's something worth keeping in the back of your mind as an important protein. We're starting to see research looking at how can we get rid of these aggregates of this protein in the brain, and this is a very active area of research that we think maybe just focus not just on treating symptoms, but actually trying to treat the disease itself. So the next thing I want to talk about is how frequent is it. This is a pie chart, somewhat complex, but describes a little bit of what kind of changes do we see in the brain in people who've died with dementia, as we'll define in a minute or so. And what you can see is that in the real world, people have a variety of causes. In blue are people who have Alzheimer's disease. But what you might notice off to the side is that many of the people who have Alzheimer's disease also have Lewy body changes in their brain. So their so-called Lewy body variant of Alzheimer's is actually more frequent than Alzheimer's alone. Also, sometimes we see Alzheimer's with Lewy bodies and vascular disease or stroke. And then sometimes we see Lewy body disease just in and of itself. So this is a fairly frequent pathology. And in fact, if we change this slide and now highlight in orange everybody that has Lewy body pathology in their brain, you can see that it's about half of people with a dementia at the time that they've died have these Lewy body inclusions in their brain. So this is a frequent pathology we think that underlies many cases of dementia that we see in the elderly. So what is dementia? I like to define this in part because people often have a misconception of how doctors use the term dementia. I think you hear the word, it's a horrible word, and you often think of somebody in a nursing home lying up in a curled position and not able to do anything for themselves. But actually dementia is a much broader term. And when we diagnose it, there are 3 components that we look at. Number 1 is that there has to be a change in thinking skills. In this circumstance, we call cognitive domains. So things like memory, judgment, finding your way around in place, language skills, and even behavior changes can fit under this category. So if we have this change, then there has to be a decline from a previous level of functioning. It can't be dementia if you have somebody who already has a disability and they've maintained that same level of disability. It's not a decline, then that doesn't really come under the definition of dementia. And then finally, the most important part of the diagnosis is a decline from ability to function at work or at usual activities. And obviously that's somewhat variable. If you're still working, your demands may be much higher than if you're retired. But these are I think really I'd like to focus on these 2 components. You have to have a change in your thinking skill, and it has to have a functional impact in order to fit that definition of dementia. Now, strictly speaking, if I have a younger onset patient with dementia, and let's say they have a change in their thinking skills, and they can no longer hold their job, but otherwise they're completely independent. Let's say they retire early, and they're managing their day-to-day lives. Because they have not able to do something that they used to be able to do because of their thinking skills, they fit the criteria of dementia, but they may be up and around walking. You would see them. You would never think that this is somebody who has a diagnosis of dementia. So again, it's a very broad term, but I think it's good to define what we mean by that. So now let's go into the Lewy body dementias. And we call that with a plural because there are really two disorders that are underneath this umbrella term of Lewy body dementias. There's Parkinson's disease dementia, or dementia that occurs within the context of existing Parkinson's disease, the motor disorder. And then there's dementia with Lewy bodies, where people start with a disorder in their thinking skills and may later develop some of the symptoms of Parkinson's, motor symptoms. So again, we have, and for Parkinson's dementia, really again, the criteria that we use for that diagnosis is that somebody already has a diagnosis of Parkinson's. So this is somebody, let's say, who has a resting tremor and has responded to therapy, sort of typical case. And then maybe 4, 5, 10 years into the course of their motor Parkinson's, they start to develop thinking skill issues, and if they're severe enough and they're affecting their day-to-day functioning, then it's called a dementia. So the diagnostic criteria for dementia and Parkinson's is, or Parkinson's disease dementia, is that the dementia occurs in the context of already existing motor Parkinson's. So you can see you fulfill these criteria over here for dementia, but it occurs after the onset of the motor symptoms. The other Lewy body dementia we call dementia with Lewy bodies. And these people, these are the criteria for that disorder. And we start with the first part here, which is they have to have a dementia. So they have to have that term of the cognitive change that affects their day-to-day functioning. Then they have to have certain features that are relatively unique to dementia with Lewy bodies, maybe not individually, but certainly in combination. So if they have 2 of these 3 core features, we consider them to have probable dementia with Lewy bodies, and that means fluctuations in thinking skills, attention, alertness, visual hallucinations, and features of motor Parkinsonism. To be more specific, people with dementia with Lewy bodies can have quite dramatic changes in their thinking skills or their level of alertness from day to day or even from moment to moment. And I've had patients who've been taken into an emergency room with the thinking that they had somehow gone into almost like a coma where they can't be woken up, and then spontaneously wake up and their brain scans and their blood tests all look very normal. And a lot of family members of patients will tell me that they can tell early in the day if this is going to be a good day or a bad day, and on the good days it seems like they're almost back to normal, and on their bad days they can be very sleepy, very confused, that sort of thing. So these marked fluctuations, much more than you see typically, say, in pure Alzheimer's disease. The visual hallucinations can be very distinct. Most often they're of what I call animate objects, children, people, animals, dogs, cats, etc. Usually during the day, very vivid, very real looking. Many patients aren't bothered by them, and so we call those, often call them the happy hallucinators. But some people can be very disturbed, and that will determine whether we treat those. And then, as I mentioned, features of Parkinsonism. So this is the classic resting tremor, slowed movement, stooped posture, shuffly gait, tendency for falls, those sorts of things. Many of these patients with dementia with Lewy bodies don't have the tremor, but most often have the walking disorder, the slowed movement, the stooped posture, those sorts of things. There are some supportive features, and probably the most important one that I look for clinically is something called REM sleep behavior disorder. And that's where patients act their dreams out. So normally during our dream sleep, we're relatively paralyzed. We don't move much. But in individuals with Lewy body disorders, they tend to lose that suppression of activity during dream sleep and often act the dreams out. It's usually the bed partner that will mention this, that every once in a while they get hit, or the patient will fall out of bed, or they'll be yelling and screaming, these very active dream sleep. These patients can be very sensitive to certain antipsychotic medications or neuroleptics, and we need to be very careful. One of the important reasons for diagnosing this disorder. And there is a scan that's supportive of the diagnosis, and sometimes we will do that. Lastly, I want to mention the so-called 1-year rule, which is that if in Parkinson's disease the dementia occurs within the first year or precedes the motor Parkinsonism, then by definition we call that dementia with Lewy bodies. If, however, the Parkinson's, the motor symptoms exist for a year or longer before the dementia kicks in, but then dementia occurs later, let's say 5 or 6 years later, then it's Parkinson's dementia. These two disorders that are under that umbrella of Lewy body dementia are very similar. They all have motor Parkinson's. They can all have hallucinations, the fluctuations. They can have the sleep disorder. And the question is it all timing? And pretty much, yes, it is. And of course, one of the important questions is, are these two disorders, how are they related? Are they in fact just a variant of the same disease? With some people starting more with the cognitive problems, the thinking problems, some people starting more with a motor problem. So that's something we're going to try to answer with genetics, but before we get into the genetics, I want to do a little bit of an introduction to genetics, and I threw a few cartoons in there. So this fellow says we've isolated the obesity gene down to one of these two, and I'm going to make a guess here that maybe it's this guy here. So pretty much all of us have 23 pairs of chromosomes. We get one from our mother and one from our father. So in this circumstance, this person got this chromosome, let's say, from their father, and this one from their mother. And that means that we get 2 copies of every gene, one from mother and father, and that's very relevant to our next slide. This is the so-called sex genes down here. If you have 2 Y genes, you are a male. If you get an X and a Y, you're a female. So let's go into the inheritance patterns. There are 2 major inheritance patterns. One is called autosomal dominant, which means that if you inherit that gene, you will get the disease. So let's say in this circumstance, you get this person, this father, has inherited one gene from his mother, one from his father, and this particular gene has the disease gene in it. Then he has the unaffected mother, and they pass one each to each person of their 4 children, for example. And there's about a 50-50 chance that one of them each time will get this abnormal gene. And if they get that in an autosomal dominant pattern, they will get the disease. And usually what you see in these families is that as you go over time through generations, about half the people in the family will have the disease that's linked to the gene. These are actually relatively uncommon genetic abnormalities. There are a few that are strongly linked to things like Parkinson's disease and Alzheimer's disease. We've not found a clear one for dementia with Lewy bodies, but these are rare. But when you get them, you'll see this about 50-50 chance for each person to get the disease. On the other hand, there's something called autosomal recessive, which means that you have to get 2 copies of the gene in order to get the disease. And so your chance there usually is about 1 in 4 of getting both a gene from your mother and a gene from your father that gives you this unlucky outcome of 1 in 4. Some people will inherit one gene of abnormal gene, but not from the other parent. In those circumstances, they're what we call carriers, which means they're kind of back up in this circumstance. And then sort of a lucky 1 in 4 will get 2 normal genes, and they can't pass the disease on at all. Often what you'll see in many circumstances is this is where a disease might skip a generation. For example, if these 2 parents had these 2 children, neither of them look to be affected, but if they then marry somebody who's also a carrier, one of their children could get the disease. So this is something that we sometimes see. So this complexity of genetics is quite more complex than the simple sort of addition that we just talked about. She says your weight problem is partly genetic and partly Boston cream pie. And in that context, what we find now is that most genetics that we're seeing, particularly as it relates to diseases of the brain, are related to risk. So you inherit a gene. If you get it, your risk for the disease goes up, but you don't necessarily get the disease. And one really good example is something called the ApoE gene, which we all inherit a copy from our mother and a copy from our father. And you can get a variant 2, 3, or 4. And we know if you inherit the variant 4, you're at increased risk for Alzheimer's. If you carry 2 4s, so you got a 4 from your mother and a 4 from your father, you continue to be at increased risk for Alzheimer's, but you won't necessarily get the disease. So just to emphasize, these are risk genes, so you're increased risk, but you can even have 2 copies of the risk gene and never get Alzheimer's disease. I have a case of a woman that we followed who lived into her 90s with 2 E4 genes, donated her brain to our research program after she died, and had not a single change of Alzheimer's disease in her brain, which just goes to show you it truly is a risk gene. You're at increased risk, but you won't necessarily get it. And of course, I always like to tell people, even if you don't inherit that risk gene, you can still get the disease. What I think is more likely coming into play on the bottom right here is that ultimately we're all inheriting a variety of risk genes, and it may be the combination of these genes that actually determines not only if you're going to get the disease, but when you might get the disease. And I think we're starting to even find variants that actually reduce your risk for disease. So there's a known variant now, gene variant, that reduces your risk for Alzheimer's. So they may counterbalance, for example, this E4 risk gene. And so, as always, the more we know, the more we realize it's very complex. So that's your genetics 101, and let's talk a little bit about the genetics of Lewy body dementia. So you saw this slide previously, and one question again is, are Parkinson's disease dementia and dementia with Lewy bodies just a variant on a spectrum of the same disease? One way to answer that question from a research perspective is, do they carry the same genes? Are the same gene risk factors seen in dementia with Lewy bodies as what we see in Parkinson's disease dementia? Or do we see different risk genes that suggest that their underlying biology, so to speak, causes are different? So some of the work that I've done in this area is relevant to this autopsy series. So we really well defined what disease these patients had at autopsy, but we had their genes to do some genetic studies. One thing that I do want to mention is that we often see, as I mentioned, I think earlier, that you can see Lewy bodies in Alzheimer's disease. This is a study we did in actually familial forms of Alzheimer's. These are autosomal dominant gene changes that if you get them, you will get Alzheimer's, and you often get it at very young ages, in your 40s and 50s. And what we found in those individuals who had died and donated their brain to our research program is that many of them, as you can see, 60 to up to 100%, had some Lewy body changes in their brain. So we have this connection between Parkinson's disease and dementia with Lewy bodies, but we also have some sort of connection with Alzheimer's disease, and that has kind of confused the field a little bit. So the one question we have is dementia with Lewy bodies just a variant of Parkinson's disease, Parkinson's dementia, or is it a variant of Alzheimer's? And I'd like to lay out this figure here, which really shows, I think, my original theory behind this, which was that people with Alzheimer's and Lewy bodies were just a variant of Alzheimer's disease, like we saw with those familial forms of Alzheimer's a few slides ago. And that the patients who died with what I might call pure dementia with Lewy bodies, that just had Lewy body changes in their brain, not Alzheimer's disease, were just a variant of Parkinson's disease. And these are really 2 separate disorders, sort of an Alzheimer's disorder and a Parkinson's disorder. So we started to look at the genetics to see if we could figure that out. And this is a study I did with my colleagues in Seattle and actually colleagues from around the country, many of them from the East Coast, the Midwest, etc., looking at whether a gene that we know, I mentioned earlier, that's linked to Alzheimer's, do we see that as a risk in, say, dementia with Lewy bodies? And we defined these cases at autopsy. So these people, we knew whether they had Lewy bodies. We also knew whether they had Lewy bodies with or without Alzheimer's disease. What we saw was that this gene variant, the ApoE4, occurred in about 7% of people who died who had no changes in their brain of either Alzheimer's or Lewy body disease. we saw that in Parkinson's patients with dementia, that they had that gene about 19% of the time. So that was higher than we expected than controls. What was also more of a surprise, though, is that patients who had just the dementia with Lewy bodies had about a 30% chance of carrying that gene, and the people with Alzheimer's with or without Lewy bodies had a 40%. So it was a little bit of a mixed finding, but what we did find was that that ApoE4 gene, even in diseases where we didn't have Alzheimer's, these Parkinson's dementia and what we call pure dementia with Lewy bodies, even these cases had an increased frequency of that E4 gene, suggesting that this Alzheimer's gene may also be a risk factor for people with the Lewy body, pure Lewy body dementias. Another group at the Mayo Clinic also looked at these issues and found basically the same thing. They found that, in fact, people with pure dementia with Lewy bodies tended to carry that, more likely to carry that ApoE4 gene. When they asked this question, the next question, though, is because they saw this ApoE4 association, was it just associated with the amyloid that we tend to see deposited with Alzheimer's disease? But when they looked for other Alzheimer's genes, they did not see that link to these dementia with Lewy body cases. So it turns out, again, more complicated than we'd like it to be. Here's one Alzheimer's gene linked to Lewy body dementia even when they don't have coexistent Alzheimer's, but we're not seeing other Alzheimer's genes linked. Another study we did with a group at Penn, the University of Pennsylvania, was we looked at people who had died with Parkinson's with or without dementia, and we were able to tell whether they had just Lewy body changes in their brain, some of them had a coexistent Alzheimer's disease. And what I circled here was the fact that we found that in patients who died with Parkinson's and had dementia, they had a higher frequency of this ApoE4 gene even when they didn't have Alzheimer's disease. So here's an Alzheimer's gene linked to dementia and Parkinson's even when they don't have Alzheimer's. So confuse the picture a little bit, but again suggests that this Alzheimer's gene may be doing something more than just Alzheimer's disease. So then we switched. So this is, do we see Alzheimer's genes linked to dementia with Lewy bodies and Parkinson's disease dementia? And in fact, the answer was yes. The next thing we did was we looked to see whether genes that are linked to Parkinson's disease, do we also see them linked to dementia with Lewy bodies, Parkinson's dementia, and probably more importantly, Alzheimer's with Lewy bodies. Again, given my original theory, Alzheimer's with Lewy bodies should look just like Alzheimer's and shouldn't have genes that are a risk factor for Parkinson's. And in particularly, we looked at a risk gene called GBA, and I'm going to keep calling it GBA because it stands for glucose cerebrosidase, and I'm sure it's easier to remember GBA. So GBA is a gene that we know is linked, if you carry two copies, so autosomal recessive, that you get a disease called Gaucher's disease. It's most notable for its effect on liver, generally in people who are younger, pediatric patients. One colleague at the National Institute of Health actually noticed that many of her patients with Gaucher's, their parents, who must carry at least one of these gene abnormalities, but not both, actually seem to have Parkinson's disease a lot. And that subsequently led to a number of studies that demonstrated that this is a risk gene for Parkinson's disease, that if you carry that gene, one copy, you don't get Gaucher's disease, but you do have about a 7-fold increased risk for developing Parkinson's. Now, your risk and my risk, if you don't carry this gene, is about 1 in 100 for Parkinson's disease. So your risk if you carry it is about 7 in 100. So it is a risk gene. 93% of the time, even if you carry the gene, you don't get the disease. But it is definitely linked to Parkinson's. So we went back to our study of people who we'd gone through, looked at autopsy, and looked at what the frequency of this Parkinson's-associated gene mutation was to these various groups. And what you can see at the bottom here, in controls, what we saw was about 1% of the time we saw that gene change. In people who died with Alzheimer's without any Lewy body change, then it's about the same, about a 1 in 100 chance. In the pure dementia with Lewy bodies, the one we thought we'd link to Parkinson's, we saw about a 7-fold increase in this mutation, exactly what we've seen in Parkinson's. So sort of confirm this idea that pure dementia with Lewy bodies might be linked to Parkinson's disease. What was a bit of a surprise, and contrary to my theory, I thought these patients with Alzheimer's and Lewy bodies would look like Alzheimer's, but in fact, they also had an increased frequency of this gene mutation. So suggesting that those patients not only carried risks for Alzheimer's, but possibly carried risks genes for Parkinson's disease. So, getting back to my original question, and sort of, which is dementia with Lewy bodies just a variant of Parkinson's? Well, they do have similar changes in the brain. They have very many shared clinical symptoms and some shared genetics. On the other hand, we see that dementia with Lewy bodies also shares some pathology with Alzheimer's, frequently coexistent Alzheimer's disease, or with some of the plaques of Alzheimer's, and they share some of the genetics, the ApoE. So, my original theory was wrong. And in fact, my subsequent theory is there's a tremendous overlap. And in fact, these diseases are often linked in many ways together. We see Parkinson's genes in both the Lewy body variant of Alzheimer's as well as the pure dementia with Lewy bodies. We see Alzheimer genes actually in all three of these categories over here. So there is some crossover. We're all bringing a wealth, if you want to call it such, of genetic material as we move into our older years, and that probably these combinations determine which of these pathways we ultimately end up going down. These sorts of studies can't be done without a lot of collaboration. I haven't even added the Cleveland Clinic to this list now, but all of my colleagues back in Seattle, where I was up to about 3 years ago, colleagues around the country, have all contributed to this work. So I'm going to end there and answer questions and sort of kind of leave this as a symbolic overview of our genetics. Thanks for your attention.
All right. Thank you, Dr. Leverenz. We do have a number of questions that came in both during the webinar itself and when people were registering. So we'll go through as many of those as we can today. I'd like to start. Thank you. I'd like to start with some that focus specifically on genetics and then others on risk. So, as you shared with us, we know some of the risk genes that increase the risk in DLB and in Parkinson's disease. Are there any that would indicate whether there is an early onset component of Lewy body dementias?
Well, I think there are some genes, and again, those are ones that are in that autosomal dominant pattern, where if you inherit the gene, you're going to get the disease. Those patients tend to get the disease at a much earlier age than is typical, so more like in their 30s and 40s. In fact, the gene mutation in that synuclein gene, or when people inherit an extra copy of that, those people often have an earlier onset of their either Parkinson's or dementia with Lewy bodies.
And is there any sense as to how far in the future it might be before families can consider requesting genetic testing? I think we see a lot of interest in knowing, is it time? How early in our life should we get tested? How many people in our families who have LBD or a related disorder suggest that this might be a genetic component? So, what do we think the future is going to look like for genetic testing?
It's a great question, and I think right now this is a research tool. However, the more we understand about the genetics of Lewy body dementia, the better we're going to be able to answer that question down the line. Obviously, one of the things that's really going to drive that question is when we have a treatment that actually treats the disease or prevents the disease or delays the onset of the disease. When we have those kinds of what we call disease-specific treatments, those disease-modifying therapies, then we're going to want to know, who's at increased risk. And that's why this research, I think, is so important. It helps us, in part, answer some of these basic questions. How are these diseases related to each other, et cetera? But ultimately, what we really want to know is, how do we predict if somebody's at higher risk? How do we tell that, in fact, they're going to get the disease? This goes to some of our biomarker work. And then when we have that treatment, then we apply that treatment before you even get symptoms or at the very earliest stages of symptoms. That's where that's the goal in the long run.
Okay, thank you.
But to reiterate, at this point, we don't recommend that. There is no genetic testing that we recommend for people.
And I think that's really important. We're seeing a lot of questions about resources like 23andMe or Ancestry.com, genetic testing that people can look to online resources for. So at this stage of the game, there's really not a place for that. There's not a role for that in LBD yet. Let's shift to risk a little bit, because I think that's so closely related to the genetics in people's minds. So let's identify for people beyond the genes themselves, what other factors do we know are risk factors for the disease?
Well, there's not a lot we know, and particularly around dementia with Lewy bodies. For Parkinson's disease, it's been fairly well established that people who are exposed to higher levels of pesticides, insecticides, are at a higher risk for developing Parkinson's. Again, it's not an all or nothing. I remember very distinctly a patient I saw, actually not a patient, a control person without disease, said, my friend got Parkinson's, that's why he was involved, and we used to work in the fields together, and we would both get sprayed with the pesticide, same amount, same time, yet he got Parkinson's and I didn't. We are starting to see some evidence that environmental susceptibility to environmental risk factors, genetics may play a role for that. For example, the protective effect that we see with caffeine in Parkinson's seems to be protective only in individuals who carry a certain gene variant. So there's sort of an interaction here between environment and gene. I suspect that some of the environmental factors that we see are linked to Parkinson's may ultimately be linked to dementia with Lewy bodies, but we don't really know that yet. The only other risk factor, and again, this kind of gets back to genetics that we're very clear, is that men tend to be at higher risk for the Lewy body diseases than women. It's not all or none, but definitely men seem to be at higher risk, whereas we know that women tend to be at a slightly higher risk for Alzheimer's disease.
Okay. And REM sleep behavior disorder. Certainly there's been increasing attention on that and its risk. Can you kind of review how that relates to both Parkinson's and Alzheimer's disease as well as DLB?
Sure. So as I mentioned before, REM sleep behavior disorder is a disorder that in which you act your dreams out, in the normal, somewhat semi-paralysis that you have during dream sleep, in fact, goes away and you act your dreams out. So people, when they are there, they don't often know that they've done this, but when you wake them up, they'll tell their bed partner, I was chasing somebody was chasing me. Usually it's some sort of action dream, and they'll literally be acting it out, and they'll be running in bed or hitting out to get rid of somebody that's threatening them. So that's the clinical syndrome. One of the reasons we think that's so important is that many people will develop that as the first symptom of either developing later Parkinson's disease or dementia with Lewy bodies. So we've even seen evidence of people having that symptom for decades and then later developing one of those two disorders. In the limited number of patients who've had proven REM sleep disorder by a sleep study and who've come to autopsy, about 95% of them will have that Lewy body pathology in their brain. So it's very strongly linked to a risk for these Lewy body disorders. But some people will have REM sleep disorder and never develop anything, but your risk goes up over time that you will. And there's a lot of interest in looking at those individuals, again, as a sign that we should intervene early, ultimately, with some of these drugs that might be useful. In terms of genetics, I'm not aware, maybe Angela you are, I'm not aware of any genes that have been specifically linked to the REM sleep disorder other than the ones we know that are already linked to the Lewy body disorders in general.
And I certainly haven't heard of any either. I just know that it's, it's a known risk factor. I think we've gotten a couple of questions that pertain to non-neurological disorders like Lyme disease. Do we know that there are any other medical conditions that might affect a person's risk of later developing LBD? And we got a similar question about the use of medications. Are there any medications that earlier in life may be associated with increased risk?
So I'll take one each at a time. And we know that certain medical issues have been linked to an increased risk for Lewy body. We don't know if they are causing the problem or in fact are just earliest symptoms. And I think most of us believe it's actually the latter, that it's actually a sign of very early disease. One of these is constipation, which of course is extremely common, and not everybody who gets constipated gets Parkinson's or dementia with Lewy bodies. But we do know that we can see some of those Lewy body changes in the bowels themselves, in the nervous system of the bowel. And some of the areas of the lower brain that control things like bowel movement and so forth also can be affected very early. And so we think that this symptom kind of gets linked to it in that circumstance. Again, the vast majority of people who are constipated, so if you're constipated, doesn't mean you're going to get these diseases, but we do see this sort of link. There are some subtle heart rate changes that have been linked as well, but again, we think because of the Lewy bodies are affecting the nervous systems of the heart, they may be affecting how well the heart responds in certain circumstances. Not very specific, though, similar to the constipation.
Okay.
Did you want me to talk about medicines?
Please do.
Okay. So the other half of that question is, are there medicines? And we know there are medicines that certainly increase your risk for exhibiting the symptoms. We don't know of any that cause the disease, but certainly the one that we worry about the most, as I mentioned earlier, are the antipsychotic medications, the medications originally designed to treat schizophrenia, for example. And some of the classic ones, such as haloperidol, can make a patient with dementia with Lewy bodies or Parkinson's become severely rigid in a very short period of time. And it takes them a long time to recover from that. I've had a number of families tell me a patient is allergic to Haldol or haloperidol because they got it because of their hallucinations, and then they couldn't move for weeks on end. Some patients get so stiff that they have to go to the hospital and to be taken care of because they can't take in enough fluids and things. So we do know that those kinds of drugs can increase the symptoms of the disease. We don't have any drugs that clearly are linked to an increased risk of the disease itself.
Okay. So we had a question come in that is specific to anesthesia, and whether or not anesthesia is linked to perhaps triggering the onset of LBD. I know certainly I've had that experience with my father where it seemed that an early exposure to anesthesia was when we saw the first signs of LBD. So, is there a possibility that anesthesia exposure is a risk for developing LBD?
So it's another good question, and certainly a common theme that I hear. My father went in for his prostate surgery and came out of surgery in anesthetic, and he was very confused, and he started hallucinating, and he's never been the same since. And I think we don't have a clear connection between anesthesia and the disease process itself. What we don't know is, does the anesthesia in any way accelerate the disease? I think most of us think that it doesn't accelerate the disease, but in somebody who's susceptible, in other words, say they're on the brink of developing the symptoms of the disease, they already have it going on in their brain, the anesthesia helps bring out the symptoms. And then by the time they sort of come out of the effects of the anesthesia, which can be months, you're really starting to see has started to kick in. So I think it's a little bit like the straw that broke the camel's back. I think it is what most of us believe. You often see that as well with infections and things. People will get a bad pneumonia, get sick in some other way, and then you see these symptoms come out at that point. And I think what's happening is a person's reserve is lowered. They're at the very earliest stages of the disease. It may not quite have had symptoms yet, and then the anesthesia, the infection, kind of are that last straw that really kicks the symptoms in. But I think there's still worth looking at, and some of the research I've been involved in has been looking at things like inflammation in the periphery, in the body, and how that might interact with the brain, and how it might interact with the disease itself, not just in terms of aggravating symptoms, but actually does it change the disease in any way.
Okay. We have a question that, I'm sorry, go right ahead.
I was going to say important questions, but I don't know that we have the full answer to them yet.
Okay. Here's another one that goes, again, about an overlap with other medical conditions. Are the genetics for LBD at all overlapping with other conditions such as ADHD or even things like Asperger's or bipolar or psychiatric conditions?
So I believe there was one report out in the literature, but I haven't seen a confirmation of some link between ADHD and increased risk for Lewy body dementia. And I haven't seen that confirmed in any way. I have not seen any link between the genetics of those disorders and the genetics of Lewy body disease. As far as I can tell, we have not seen any overlap. As I said, we've seen some overlap between Alzheimer's genes and Parkinson's genes and Lewy body dementia, but we haven't seen with some of these other diseases that were mentioned, including the psychiatric illnesses.
Okay. Here's a good question about genetics and brain autopsies. When a person has a brain autopsy, is the genetic screening part of the process, or can that be requested to associate the what is found clinically and in the brain with genetic factors?
Great question. This is something we do try to do within our research studies at this point. And so as we start to study people with the Lewy body dementias, not only do we try to characterize them clinically, we usually try to get a blood sample so we can get DNA for analysis, and then at autopsy. And we try to pull all three of those components together. This is something that's generally done within a research center that's specifically studying the Lewy body dementias. And so if you wanted that kind of analysis done, you'd have to participate in a research study. And if the genetic analysis did not find a causative gene, like one of those autosomal dominant genes, usually you won't get a whole lot of information back about that, at least at this point. So most of that kind of more detailed analysis of both genetics, clinical symptoms, and autopsy findings are a part of research. Now, Angela, as you know, we're in the process of trying to develop just those kinds of research studies at a variety of sites that are interested in Lewy body dementia, and we're hoping by the end of the fall we can announce that these research centers have been established.
Wonderful, because that was going to be my next question is, what has to happen in order for us to really be able to do the kinds of studies that allow us to have that, enough power. Perhaps you can talk a little bit about the consortium, what's going on in Europe, and, I don't know if you're familiar with any of the findings that they have published, within the last year or so, but, what's the benefit of that type of organization?
Well, this is very relevant to genetics. If I talk to my genetics colleagues and I say I have 200 DNA samples, they'll always tell me they need 400, and if I tell them I have 400, they say they need 1,000. So the more patient samples that we have, the better the genetics we can do. And one of the problems that we have frequently is that the numbers of patients that we have that are well characterized, that may have autopsy, is relatively limited at any one research site. And so we've started a real effort, and this is really a worldwide effort, to start to develop collaborations amongst various sites that are interested and willing to do this research. For example, as you mentioned, there is a consortium in Europe and have started to publish a few papers that really couldn't, the kind of data they're generating couldn't have been generated by any single participating site. There wouldn't have been enough cases to really make the science work. But by pulling together a dozen sites and pulling together patients from all the different sites, they're able to generate quite a lot of data that allows you to start looking at things like genetics, risk factors, things of that nature. As I've already mentioned, we're trying to set up a similar a group in the U.S., and we're just waiting on funding issues around that. So we have the LBDA has been very helpful in our efforts to pull this together, and we should, as I said, know by the end of the fall if we've been successful. And I've even talked to a colleague in Canada now who is in charge of an effort to pull together a consortium there. And I've been in discussions with the group in Canada and with the leader of the group in Europe, and I think our hope is that we may make this an international consortium in some ways where the Canadian, the U.S., and the European sites, and hopefully maybe Asian sites, can participate together. And the larger the numbers, the more we can learn.
Fantastic. So let's shift to a couple of other questions that come in that are more research related, since that is kind of the primary focus here. We've had a question that says, are there any results yet from clinical trials on Lewy body vaccine? Where does the field stand on actually being able to do disease-modifying therapies?
Well, actually, I think I literally got an email from the Michael J. Fox Foundation this morning that their phase 1 vaccine for Lewy bodies actually showed some positive results. And right now, phase 1 means it's sort of a safety, and do they have any evidence that it's affecting that synuclein protein? And they showed that it was safe, and they had some evidence that people were generating antibodies to that protein who got the vaccine. So that's really the very first step, but it's a very big step, right? If a drug is not safe, then you just, at phase 1, it just cuts out, and that's what happens with a lot of drugs. So here's a vaccine that seems, at least so far, to be safe, and the next thing will be to do something what we would call a phase 2 trial, where you start to look at, so how frequently should you give that vaccine, and is there any evidence that it's affecting the disease? So it's a really nice outcome, and literally was announced by the Michael J. Fox this morning. So if you went to their website, I'm sure it's on their front page as one of their big news items.
And very similar timing. There was news within the last week or two about progress on the Alzheimer's front for possibly disease-modifying agents. So is this something that how can you connect the dots for our listeners on how advances in Parkinson's and Alzheimer's then will ultimately line up with LBD families?
Right. So I think they're very important, as we've already discussed today. There's a lot of crossover between the diseases. We think Lewy body dementia has connections to both Alzheimer's and Parkinson's disease, and I suspect strongly that therapies that are effective for Parkinson's or therapies that are effective for Alzheimer's may have applications, at least to some patients with Lewy body dementia. So I think, in fact, when I talk to industry, and you saw that I consult with them, one of the things that we discuss is the fact that next step for a lot of these drugs, let's say we have a vaccine for Alzheimer's that works, certainly one thing that they're very interested in is, will this vaccine work in Lewy body dementia? Similar, I think we'll see the same thing with Parkinson's. And I think it's similar to cancer, as you're seeing now. Breast cancer is not always treated exactly the same. Various variants of the disease are treated in various ways. I think as we personalize our medicine for Lewy body dementia, we'll be looking at how much Alzheimer's, how much Parkinson's, what are the genes, and that'll help us predict what's going to be the best therapy for a particular patient.
All right, we have just a few more minutes left, but I want to sneak one or two questions in about clinical care if I can. And one of the topics that brought in the most questions, which and understandably so, is tied to prognosis. It's tied to the progression of the disease. And so if I were to sum up, about a dozen questions that I received on this topic, I would say, how long does the disease last? What can families expect from a prognosis standpoint? And how do they know what stage that they're living with right now? Are there any clear lines that indicate you're in an early stage versus a moderate stage? What can you give them that will help them gauge where they are in progression?
Well, that is a question I get a lot, and I always am vague in my answer because I don't have a clear answer to that. I've seen a real wide range of variability in how people do with Lewy body dementia, ranging from people who, in the various worst of circumstances, have died within 3 or 4 years, and other people's where they seems like they've gone on for almost 2 decades. So there's a real wide range, which is why I'm very careful when I'm sitting down and talking to a particular patient and their family about telling people how long this is. One thing I do emphasize is this is something where it's unusual unless you get sick in another way, that, if I'm seeing them at the early stage of the disease, that you're going to be, in a nursing home in a year, or you're going to die from this in a year. So this is something that happens over years. But giving a particular prognosis is difficult. Again, what I will tell families is if a person with this disease gets sick in another way, if they have to have major surgery with major anesthesia, they get very sick with a pneumonia, they have a stroke, these other things will really aggravate the disease and will accelerate things. So accelerate the disability that they get from the disease. So one of the things that I try to tell people is the better your general health is, the better you'll do with this disease. So we try to control all the other things that we can control. And then what was the second part of the question?
How do people gauge where they are in the progression of the disease? Are there any defined stages like there are in Alzheimer's? And if they're not, what can families do to ballpark where they are?
Yeah, I think some of it's timing, how long has the disease been going on for, but a lot of it has to do with the disability. Are they able to, we don't have a clear staging system for Lewy body dementia at this point. Often we'll try to apply the Alzheimer's staging systems, which don't work perfectly because you have different kinds of symptoms. But I often base it on functionality. Some of the simple questions I ask, for example, is, do you feel comfortable leaving the person at home for the afternoon? Would you feel comfortable leaving town for a couple of days? Those are people who are let's say the mild stage could be left alone at least for an afternoon, maybe even sort of pre-mild if they could be left alone for a few days and they could manage for themselves. As they become more dependent on their caregiver, you're starting to talk about mild to moderate disease. Usually for severe disease, I'm going to be thinking that this is a person that really requires help with everything, and is not independent in any kind of way. And then, of course, in Alzheimer's we talk about profound, and these are usually individuals who are in nursing homes that are the sort of classic dementia patient sitting in a bed in a curled up position.
So that's a significantly advanced stage of dementia in general.
Exactly.
Okay. So we are just about out of time. I'd like to thank you once again, Dr. Leverenz, for providing a really interesting and informing presentation and for making time out of your very busy schedule for us. We really appreciate it. And I'd like to thank everybody else for making time out of their schedules to join us today. This event was sponsored by an unrestricted educational grant from Axovant Sciences. Most LBDA programs are made possible through donations, so if you'd like to make a gift, please visit our website, lbda.org or call our office at 404-935-6444. I hope you'll all join us again on Monday, December 5th at 3 p.m. Eastern for our next Ask the Expert webinar when Dr. Brad Beauvais, the chair of the Division of Behavioral Neurology at Mayo Clinic Rochester and professor of neurology in the Mayo Clinic College of Medicine, will present Ask the Expert, Comprehensive LBD Clinical Care. That's a good opportunity for you to learn all about medications and therapies that are helpful in the disease and to ask questions of an expert. So again, thank you for joining us today, and we hope you enjoy the rest of your day.